The upper quarter screen can be utilized at the beginning of the examination sequence in order to help screen or rule out for the presence of myelopathic symptoms or radicular symptoms. So, say for instance a patient comes in and is complaining of some mild neck pain with referred pain down past the shoulder, maybe not even into the elbow joint, or most definitely all the way past the elbow joint into the hand. Both of those situations are going to be instances where you as a clinician are going to want to execute the upper quarter screen. So, the upper quarter screen is basically going to consist of going through an active physiological range of motion for both the cervical spine as well as the bilateral upper extremities. Next, the clinician will want to perform myotome testing, followed by dermatome testing, reflex testing, as well as upper motor neuron special test. So, to go ahead and continue on and perform the upper quarter screen, what I'd like to ask my patient to do is to go ahead and bring your chin to your chest, please. Now we're looking at just gross cervical flexion. I'm going to apply overpressure, assess for patient pain. The overpressure and the assessment for patient pain is going to be common throughout every technique or execution that we're going to be asking our patient to perform. So, at this point then, why don't you go ahead and perform a chin tuck for me, please. We're looking at upper cervical flexion now. We can ask our patient to just nod his head in that position and sort of inducing an overpressure. Now then, go ahead and stick your chin all the way out towards my finger like that, making a chicken neck, and then go ahead and nod again for me, please. Upper cervical extension, looking for overpressure. All right. Now, go ahead, bring your head and just go ahead and look back. Very good. Here we'll want to provide some overpressure again, and that's going to be lower cervical extension. Next, go ahead and rotate towards me, please, Matt. Here what we want to do is again apply an overpressure, ruling out pain referred or created by this movement. And then what we can also do is we can now start to integrate our manual muscle testing or myotome testing. So go ahead, resist me, don't let me move you, please. Here we're assessing for the integrity of the C1 nerve root. We'll go ahead and perform this to the opposite side. So rotate, overpressure, and then don't let me push you again. Very good. Come back to neutral for me, please, Matt. Now take your ear and put it down to your shoulder. Here, this is side flexion with overpressure. We can perform it as I just demonstrated. Please do it to the other side, Matt. Here, what we're basically performing is a Sperling's test, which is just overpressure with side flexion. So, cervical range of motion has been eliminated as far as the execution of this upper quarter screen is concerned at this point. We'll now go ahead and ask our patient to stand off the plinth for me, and we're going to do upper extremity active range of motion. So just go ahead and raise your arms out to the side all the way up into full abduction for me, please. And link your hands behind your head, placing the patient into full external rotation. Again, the clinician can come behind the patient and apply an overpressure and adenohumeral external rotation. All right. Now go ahead, Matt, from that position again. Assume that position again for me, please. I've got a very fast patient here. All right. What we want to do is we just want to ask Matt to bring his hands in front of him and what we call release the bird, going into full bilateral elbow extension and wrist extension. All right. So now we've performed all of the active range of motion. So what we want to do is we want to continue on with our myotome testing at this point. What I'll ask Matt to do is assume a sitting position once again. Again, the order of this can be varied depending upon patient clinician preference. So here, what I'll ask Matt to do is go ahead and shrug up his shoulders for me, please. We're testing C2, 3, and 4 nerve root right now. All right, he's strong. And bring your arms out here. Abduction, again, resist. And that is testing the C5 nerve root with resisted abduction. I'm going to come in front of my patient, and I'm going to go ahead and resist elbow flexion, assessing the C6 nerve root. Great, very good. Go ahead and straighten out your arm for me, please. Position the patient's wrist into some flexion. Hold that position. And apply a force. That's testing the C7 nerve root. Next, go ahead and make a thumb for me, please. Give me a thumbs up, Matt. Now what we're going to do is we're going to apply pressure here, resisting first digit extension. This is the C8 nerve root. Go ahead and spread your fingers for me. We're going to be testing abduction at the digits, and this is the T1 nerve root contribution. Myotome testing is now complete. I'm going to go ahead and continue on with dermatome testing. So, tell me if you feel this. Keep your eyes closed for me, please. You typically want to do this bilaterally and see if there's a difference or an asymmetry between sides. So here I'm testing C3. You feel that?
Mm-hmm.
All right, we come a little bit farther out over the shoulder. Testing C4. Do you feel that?
Yep.
All right, we go right over the deltoid. Test C5. You feel that?
Yep.
We now go down to the thumb. Apply force. Testing for C6. Do you feel that?
Mm-hmm.
We go to the middle finger and do the same thing for C7. Do you feel that?
Mm-hmm.
Great. Now we go to the pinky and we test for C8. Do you feel that?
Yep.
All right. And then I'm going to come up here and do his axilla and test for T1. Do you feel that?
Mm-hmm.
All right. Very good. So we've completed active range of motion, myotome, and dermatomal testing. Next, what we'd like to do is assess for the reflexes. So I have a reflex hammer right here as so. We can test the biceps brachii tendon for the C5, C6 reflex, as well as the brachioradialis tendon for the same nerve root contributions. So I'll isolate the biceps tendon here, placing my finger directly over it, and now I'm going to apply the force through my dummy thumb. Go ahead and relax, place it right here. All right. There we go. That's a normal response. Now what we're going to do is we're going to perform this at the triceps, analyzing the C7, C8 nerve root contribution. All right, very good. And you'd want to perform this bilaterally so that way we could assess for asymmetries. Again, the brachioradialis would be C5, C6. We're actually going to go over the brachioradialis muscle belly. So here, and this is a difficult one to elicit, and we're looking for some elbow flexion. All right, great. So, active range of motion, myotome testing, dermatome testing, and reflex testing has now been executed. What we now want to do is we want to go ahead and continue on with upper motor neuron special tests if necessary at this point. So what I'll do is I'll perform Hoffman's by taking the patient's hand, basically his last 3 digits into my hand, and what we're going to want to do is on his 3rd digit we're going to go ahead and we're going to apply rapid flicks or actual tapping over the nail bed. What we're trying to assess for is a positive sign indicating an upper motor neuron lesion. A positive sign is that with repeated flicks or actual tapping here at this nail bed, what we'll see is a transient flexion in his 1st and 2nd digits. So they're kind of pinching down. After the flick, if we see that transient flexion, that's indicative of a positive test. Now, what I forgot to mention earlier was that when we actually go through the active range of motion for the cervical spine, when the patient drops into flexion, prior to the overpressure being applied, what you want to do is you want to assess for what we call a Lhermitte's sign. That is an upper motor neuron sign indicative of multiple sclerosis or just basic upper motor neuron lesion. And that is how you complete an upper quarter scope.